Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome back to this episode of the Turd Nerds. So we are still on our quest to understand the perfect prokinetic for our individual patients. We are on phase 2. Phase 1 was looking at everything that had to do with serotonin and everything that had to do with dopamine. Dr. Sand, jump us into acetylcholine.
Okay. Thank you for that awesome introduction. I'm excited.
I am pumped about getting people to poop.
Yeah, same since a true passion of mine. All right, so our next class here are acetylcholine esterase inhibitors.
Okay, can we just go really big picture before we dive into this episode and just remind us what acetylcholine does? Do you want me to give you a quick recap of what acetylcholine?
I know it's a prokinetic. But I know it does so many more things.
So acetylcholine is a neurotransmitter that plays a vital role in the central and peripheral nervous system. It's involved in muscle contraction, memory, cognitive function, and then it has a bunch of effects in the GI. So in the GI, it seems to regulate the various smooth muscles that cause contraction, glandular secretion, and motility of the GI tract, which is why we have drugs that are acetylcholine esterase
inhibitors.
Like anticholinergic drugs, which can worsen some of these motility issues and urinary retention and dry mucous membranes and all of those things.
Yep.
Okay, so an anticholinergic blocks the effects of acetylcholine in the nervous system. Mm-hmm. So basically, the anticholinergics inhibit the binding of the acetylcholine to the receptors, so it affects decreased smooth muscle contraction, reduces glandular secretion, and altered nerve signal transmission.
Mm-hmm. So it dampens the effects of acetylcholine. So these are like antihistamines and various other anticholinergic drugs.
Yep.
Okay, and so that's the drug class we're talking about.
We're talking about acetylcholine esterase inhibitors. So the enzyme that breaks down acetylcholine is acetylcholine esterase.
That is so important. Thank you for that clarification. Yes, so important.
ACE is an enzyme, and if we're not breaking it down, we have more bioavailable acetylcholine.
Which is why we're using it for constipation.
And we're increasing the activity of acetylcholine.
We got it. Really, we just want acetylcholine in the gut. We need it to move stuff.
Okay, I'm ready to dive in. Go.
Okay. Do you know any of the drugs in this class?
Not.
I do.
I know one. It starts with a P.
Yes. It's used a lot in like mast cell type stuff.
It's got a Y in there and a G in there.
Got
it. A Z?
No. It does not have a Z.
No.
I can't remember.
Peristigme. Can I buy a vowel?
Peridostigme?
Yes.
Peridostigme. Yes, that's the one.
Nice.
I played around with this drug for a little bit when I was desperate getting people to poop.
Oh yeah, that was discussed in the MCAS talks that we went to.
Yep.
Okay.
Yeah. So this class of drugs in general works by inhibiting acetylcholine esterase, which thereby increases the bioavailability of acetylcholine.
Okay, can we just go real big picture? I don't know if we can because I don't think I can.
Yeah, I'm not sure I can either.
Acetylcholine, Dr. Kapadia.
Please don't put me on the spot. Is this the drug we've used in myasthenia?
Yeah, I think it is.
Yes.
Okay.
Yep.
Okay.
Yes.
That's the context that most people might have heard of it in.
Yep.
In the conventional world.
We've got
myasthenia
pyridostigmine and neostigmine.
It was pyridostigmine that we would use.
That's the only one I've used.
Yeah.
Yep.
And so if something is anticholinergic, it increases secretion
of acetylcholine
and of like fluids, right?
That's you're thinking about anticholinergic
Yes,
drugs and
that's
like drugs in
exactly.
elderly people that we
Yes,
avoid
yes,
because
yes.
it
That's
causes.
exactly what I'm thinking.
Right.
Yeah, and that's one of the things about this class of drugs is you see systemic effects. Like, yes, they work in the gut, but we have acetylcholine everywhere. It affects like our nerve conduction, our interaction with our nerves and our muscles, and then like kind of like a stress response kind of situation. So essentially what this is doing with the increase in acetylcholine is enhancing transmission of nerve impulses at our neuromuscular junction, so we can see the repercussions for the whole body, but it can improve the tone and the signaling between nerves and muscles in the bowels as well, along with that acetylcholine being a prokinetic piece. So this is generally going to be for people who have like POTS, myasthenia gravis, diabetes, type constipation is another
Because
group
you've
of people,
burned off the nerves
because of the nerve damage.
Yeah, totally.
The effects of these drugs are they improve colonic motility and they have a ton of systemic effects.
So only large bowel, nothing small bowel.
I don't know.
I feel like one of the local teachers of MCAS and such is a big fan of using this drug for constipation.
Yep, totally.
Yeah. Even if they don't have any of those other complicating factors, although they often have POTS as well.
Yeah, and I see given commonly probably from that same person as a prokinetic. And we share some patients where that is the drug we use for all the reasons that her brain knows about. And I do see it work. So this is called mestinon generally, pyridostigmine, and it is increasing acetylcholine, increasing motility. It is approved currently for POTS, myasthenia gravis, and reversing NMBAs, which is that like paralyzing drug we give for intubations and things like that. We're not going to be using that. Most likely, I don't know, maybe.
Nope, I don't intubate anyone.
Nope.
You don't want me doing your intubation.
Yeah.
That means that means the healthcare system is in bad shape if I'm doing the intubation.
Don't call Dr. Chapatia for your intubation.
Don't call Dr. Gervich.
Or
don't call Dr.
Go to the
Gervich.
hospital, people. And this can be given in all sorts of forms. We have oral, we have IM, we can do QD, BID at bedtime, like lots of ways to give this for a dosing. It is not FDA approved for constipation, although I've seen it help with that. And the adverse effects are a lot of the acetylcholine type stuff. So we can get twitching, we can get changes in periods, like increased pain and contraction with our periods.
Interesting.
We can get dry skin, we can get diarrhea, urinary changes, like frequency changes, pains, vision changes, nosebleeds. Like it's just all over the place. I don't even know how you PARQ patients on this one, but
it is a long list.
Long list. And it's not in no one. Like it's enough. The ones I just listed off are in 2 to 10%.
And so is it approved as a prokinetic? Like not unless they have one of those other concurrent conditions, right?
POTS and myasthenia gravis. It's off-label for a lot of the gut stuff. We do have studies on diabetes patients with constipation, not specifically defecatory disorder type stuff. So like the bowel floor, pelvic floor muscles aren't necessarily the culprit. It's more like the nerve degradation piece in diabetes. Interestingly, we have a study on pyridostigmine comparing it to bisacodyl, which is a stimulant over-the-counter laxatives, and they similarly improved symptoms of chronic constipation. Also, this one can decrease abdominal distension, and it's sometimes used in peds for things like constipation and bloating. But not by me.
I have never seen it used outside of myasthenia gravis, actually outside of our local community of providers who treats things a bit differently. In the conventional world, I haven't seen it used for a lot of these other reasons. Not that it
when I
shouldn't
gave
be.
this talk at that recent lecture, one of our friends and doctors came up afterwards and said that he uses it because it's a heck of a lot cheaper than prucalopride.
I will also say it's a heck of a lot less effective.
For constipation.
Yes.
Yeah. But it can really help with bloating as well. So, it's an option out there. Neostigmine. Anyone want to take a guess on how to say the drug name of that one?
Oh, that is impressive. Just so you guys, we're looking at something that has an X, a V, and a Z all within the name.
Why don't you stick with neostigmine?
BL.
No, I'm gonna go for it. I'm gonna say it with confidence. Bloxivers. It's the Bloxivers drug. Yeah. That's completely how you pronounce it.
That
Absolutely.
honestly would be my guess too. So anyway, this is an acetylcholinesterase inhibitor too. I personally have not used this, but it is in this class of drugs. And it promotes intestinal smooth muscle contractions, augments peristalsis, similar to the last one. This one is approved for non-colon pseudo-obstruction, so not a straight obstruction, but when often that's like in kids who've been hospitalized and things like that. Systemic effects are about the same, and some may recommend continuous cardiac monitoring when we're first giving it, and recommended to have atropine available.
It doesn't seem like we're going to be prescribing
Absolutely
this one.
not. No, we do have RCTs on this for constipation, and may be really useful for diabetes folks who are really, really struggling, but again, not in my chunk of drugs.
And, I will say, we do also have other good options for those diabetic patients.
Yep.
I definitely have tried to throw this piece of spaghetti against the wall. I have not had great success.
You're taking out pyridostigmine.
I'm talking about this entire drug class. Yeah.
Okay.
Yeah.
And it just doesn't really
They're not
work.
my go-to,
No.
but again, I have shared patients that are using them for other reasons, and they seem to help as a prokinetic. I really see them help with the bloating piece, so I don't know.
Yeah.
All over the place, but someone else could probably give us more information on the alternate uses of that one. Macrolides, anyone?
Antibiotics. Yes.
Yeah.
Yes, please.
One of our favorites is naturopaths.
Yeah, we love antibiotics. Yeah,
dish out antibiotics any chance we get. They also happen to be motilin agonists. So motilin, what do you think motilin does?
Causes motility.
Oh, brilliant.
I know, it's kind of tricky, that name. Yep.
Yep. So it's debated whether humans have motilin receptors in the large intestine, and we'll talk about why these drugs can actually help with constipation, but they're not generally given for constipation. They're more like upper GI symptoms. These are going to be erythromycin.
I've used that one a lot.
Yep. Low dose. Azithromycin.
That one, do you know that is the
Z-Pack.
only antibiotic that increases the length of your telomeres?
Cool. I mean, there's some kind of cool data on it.
Yeah, and it's indicated now with the most recent updates for pretty severe COPD to keep people on sometimes, which is interesting because it's an anti-inflammatory.
Right, totally.
And so it seems to have, some
beneficial effects.
I know, it also works in the gut.
Yeah.
I'm really curious about it, and I hope we get more data on low dose azithromycin.
Okay.
I don't know a lot not data
Yeah,
yet.
I
but,
don't either.
Importantly, chloranthromycin.
I've never used that one.
Yeah.
And mitimcinol, or I'm not totally
You're
sure.
not saying it with enough confidence, Dr. Sand.
I don't use it. I don't know how to say it, but those don't really. Oh, no. Sorry, let me back up. Chloranthromycin has no motility effect.
Oh, okay. That's why I'm not using it.
It maybe binds, but I'm not going to cover it because it doesn't really do anything exciting for our bowels. Mitimcinol, or whatever it is a cool drug that hasn't come out yet. And it is derived from erythromycin. It's in preclinical investigations, at least last I checked. It is safer and stronger in its prokinetic effects. So it may be a kind of cool one as we get it. Hopefully we get it to use low dose in some of our patients. But we have animal studies thus far showing efficacy for constipation on it.
I just, half of my naturopathic brain is always like, oh, I've seen this pattern where we put somebody on chronic antibiotic use that's low dose for their rosacea, for their acne, for their chronic UTIs. Like, I've seen this pattern.
Yeah.
I've been watching it long enough. It generally doesn't end well.
I know.
But I have absolutely seen the prokinetic effects of different drugs in this class.
Yep.
So I will just tell you that these drugs personally tear me up right down the middle.
I know.
Is there data on azithromycin as a prokinetic? Because I haven't seen it be used.
Okay,
yeah, let's do erythromycin.
Right,
we know the most about that one.
Yeah. So this one at higher doses is used as an antibiotic for Bartonellas, Legionnaires, STIs, surgical prophylaxis. Like we all are familiar with erythromycin. It is a motilin agonist for the upper GI tract and gallbladder.
Oh, I didn't know that.
Low doses induce mechanical peristaltic activity in the stomach, duodenum, and esophagus. And the dosing here, so antibiotic dosing is 50 milligrams per kilogram per day.
Antibiotic, like if you're trying to kill something.
If you're trying to kill something, bugs, let's be specific here. Gastroparesis is 250 to 500 milligrams 3 times a day before meals, which is really high.
Mm-hmm.
You're like in the antibiotic realm there. But we want to limit the duration of therapy because this one can have heart effects. So tachyphylaxis is like a risk, especially if we give it for more than 4 weeks. So if you're doing it that high, just be careful. We have studies on chronic idiopathic constipation. The dosing is cool on this. It's 1 gram a day for 2 weeks, followed by 500 milligrams for another 2 weeks.
So you have to compound that.
Yeah.
Because the smallest dose
Yep.
I've ever seen in a pill is what, 50? No, it's 250 and you quarter it, so it gets you to 62.5.
62.5, exactly.
Yeah.
Yep. So the low dose range, and I have not personally used that as a constipation option,
Yeah.
but we have some data on it. The low dose, when we talk about low dose erythromycin, generally it's going to be somewhere between that 40 and 200 milligram dose. There's some data that suggests 70 milligrams may be as effective as 200, so dose low if we can, obviously lowest effective dose, but generally a cheap way to get it is to get that 250 and quarter it.
So that 1 gram and then 500 milligrams, what is that used for?
Chronic idiopathic constipation.
How big was this data set? Do you remember?
I don't know off the top of my head.
Okay.
Yeah. But interesting. It had effect, and that's all I can really speak to that. I have PubMed IDs. We can check. But the cons of this one is in the bowel, we do see effects on this one in the right colon and retrosigmoid colon, even though we're not totally sure motilin receptors exist in the colon, in the large intestine. And we have it's a cytochrome P3A4, so a lot of drug interactions you need to check, and bacterial resistance.
That one makes sense for me.
Huge. Yeah. Cautions. We've got the QT prolongation thing. Some recommend a baseline ECG first. Don't give it to patients at risk. And there is prolonged use a risk of C. diff or pseudomembranosus coli.
Of course. That makes perfect sense.
Yep. But, and maybe one of you have heard of this, but the weight gain piece.
So I always cut.
Dr. Gervich loves this.
Yeah, I
study.
do. So basically, what is it that they give? No, this is a big thing. What is it that they give to cattle to fatten them up before slaughter?
Let me guess.
Erythromycin. Like for me, I'm like, this is like, so this drug, I think when I'm differentiating when to use it or not,
if they're
I'm
underweight.
Like cachexic.
Yeah.
Like, you know what I mean? Like that, I think it's appropriate for them, but if they're worried about their weight, I'm worried about their weight.
Or you could feed them that cake you left at our house.
It was a vegan cheesecake, and it was
basically
that's the one you have in your freezer right now.
Addiction.
It was delicious and very good for you as far as cakes go.
I love it. I love all these things. Yeah. Okay. So for these people, it's cheap. That's great. It can help. That's great. It's sort of an adjunctive prokinetic agent is a lot of the time how it's used. Don't give it to your geriatric folks. Don't give it to people who may be struggling with weight stuff already, unless they really need to gain weight. Don't give it in pre-existing heart conditions. And as far as I know, there are no studies on bacterial resistance for the low dose.
Because nobody studied it.
Because no one studies it. So, jury's out.
Yeah, I don't know. My jury's in. My jury's not out.
Azithromycin, Zithromax, or Z-Pak is an antibiotic and a motilin agonist. The dosing for this is going to be 100 to 400 milligrams before the first meal. 200 milligrams works best for most. It has fewer interactions than low-dose erythromycin and no cardiac risk.
Yeah.
It does have potentially prolonged QT still.
It does?
I don't know what those doses, Dr. Stan, so you might be right, maybe if you're using lower dose, but in regular use.
These are generally for like the gastro effects, but we see its effects maybe in the right colon and retrosigmoid, bacterial resistance at this dose for sure, risk of candida.
Yeah, for sure.
Candida,
I mean,
for some of us.
all of them. Anything in this class.
Although I see that less with macrolides than with tetracyclines or...
Oh, is that true?
I don't know if it's true.
Yeah, you just see it less.
It's true for you. It's true for you.
In my training, one of a respected senior attending had said he saw less effects when he had someone on azithromycin longer term than something like doxycycline. Again, it's not a good thing if you have other options.
And my soapbox is always the same.
Right.
It never ends well.
Right.
I've been in medicine long enough.
Yep,
right.
Yep.
Yeah.
Yeah. I wonder, let's just say we have to give this for a bunch of other reasons.
Right.
If we dosed it with sac-boulardii or something like that, if that
Would
may
it help?
mitigate.
That for me is always my standard.
Yeah.
That's my
Right.
baseline.
Yeah.
Yeah.
Yeah, and again, who the heck is going to study that?
Nobody.
I wish someone would, because that would help me out.
Nobody in America, at least.
No.
For sure, nobody in America.
No.
I don't know if nobody in the rest of the world, but definitely no one in
I'm surprised they
America.
haven't come up with a combined antibiotic antifungal pill just to prevent all the things that we do to people.
This is
when
where
we
I
give them.
land with
Not
that.
enough.
I'm always like, okay, so you have the antibiotic, and then you have the antifungal. What the hell is left?
It's true.
once you're
It's true.
done?
But if you're doing a 1 week course of an antibiotic,
Right.
would it hurt to throw in like a week of nystatin in a combined pill?
I mean, there's so much nystatin resistance is really where we land.
Sure, but...
And diflucan has that. Yeah, no, I hear what you're saying. It's not a bad idea. You should patent
it's a
it.
good... Pharma should do something. Maybe there's something that they're working on.
Nothing about your generic antibiotic and your generic fluconazole is screaming big bucks for pharma.
But if they put it together, it's a new patentable drug.
Yeah, it's like that drug for morning sickness. That's
B6 and Unisom?
B6 and Unisom, and it's like $1 billion. Like no, but what they did is they made it in a pretty white pill and stamped in pink a pregnant lady's belly on it.
Oh, so cute. They know how to market.
It's worth way more.
They know how to market.
Oh my gosh, don't even get me started. So the thing about this one, like, I don't know that we have robust data on low dose, but generally what we're seeing as far as the data I reviewed is the effective dose for motility is the antibiotic dose. Again, we're not going to be using this one, but I do just like to talk on it because it is in the drug class.
Yeah. And it's not the worst antibiotic out there.
Yeah.
You know, if you need it, this one I think does less harm.
Totally. Yeah, and I'm allergic to almost all antibiotics except this one. So it is my fave.
Yeah. Yeah, there you go. Let's ride that as long as we can.
Let's do it. Let's not be allergic to that one. So our next class is opioid antagonists and PEMORAs. This is a lot of them.
Okay.
Does anyone know what the difference between opioid antagonists and PEMORAs are? Do we know what a PEMORA is?
I don't know what a PEMORA is.
Nope.
Peripherally acting mu-opioid receptor agonists.
Oh, these are all the mu drugs. Yeah, there's a bunch of them that just came out. The drug rep visited me, but not regularly, so I don't know anything about it besides that they exist.
Okay, so let's then talk about what the difference is and what PEMORAs are. So they're, like, I said, they're peripherally acting, but they're different from the ones that don't do that. So I'm going to go into the different drug classes here. Some of them are specifically for constipation, meaning people who have opioids, who are using opioids for whatever reason, get constipated for reasons we'll talk about.
I'm going to say,
duh. Seen that.
You sound like my niece Leela.
Yeah. Duh.
I mean, it's fair. But maybe they need to be on that drug for pain management, and we still need them to poop. So these are going to allow for the opioids to still affect the brain, but be blocking their activity in the bowels.
Oh, interesting.
So a little bit of background information. We have a lot of opioid receptors in the submucosa and mucosa of the digestive tract. When we activate the local mu receptors, this taking opioids, when we activate it, we reduce gastric, intestinal, pancreatic, and biliary secretions.
That's not good.
Dries them right up. We inhibit peristalsis, and we reduce the release of acetylcholine.
Okay.
So you can see why this is just a giant disaster in the gut.
Yeah.
Unfortunately, because of all of this, a lot of our laxative products, bowel regimens, dietary changes, lifestyle stuff that we would talk about with constipated patients aren't going to touch them. And some of them can interfere with opioid therapy. So PEMORAs do not cross the blood-brain barrier. That's really important. Therefore, they do not impair the analgesic effects of our opioid drugs. We've got a couple different here. We've got naloxegol, nalbendazole. These seem to be the best choices for tolerability. We'll go through them.
Are these relatively new drugs, or have
naloxegol,
we just not...
I think, is pretty new.
Okay.
It's new to me.
Yeah.
I don't know how long
definitely
it's been
new to me.
Yeah, me too.
on the market. Movantik is the drug name.
Yeah, I have not seen it.
But these are going to be approved for like opioid-induced constipation, post-surgical constipation, and a lot of our oncology patients who are requiring opioid therapy. They do the opposite of everything I just said. So they increase digestive secretions. They increase peristalsis.
And so this drug class, basically, if you're on an opioid, you're given these PEMORAs.
Yep.
But we're not using them just for idiopathic constipation.
No, that's not what they're approved for.
Okay. They're only approved for opiate-induced constipation.
Yes, and I don't do research into this, but I do think affecting our opioid receptors, because we have them in our body, can be a way to help with all of the things that these receptors do. So yeah, they're involved in pain in the brain, but we have a ton of them in our gut, and it may be a class of drugs that we get more therapeutic windows to be able to help people who are chronically constipated.
Even if they're not on opiates.
Exactly. Yeah, they're just receptors that are involved in digestion, obviously. So naloxegol or Movantik is naloxone.
Oh.
Conjugated. Get ready. With polyethylene glycol.
Genius.
To keep it in the gut.
Genius.
Isn't it?
A little bit, yeah.
But I wonder if it's just helping because there's polyethylene glycol in it.
I bet it's not. Well, we know as a fact,
polyethanol
glycol is not enough for a lot of these populations.
It's true. Good point.
Also, my bet is it's probably cheap to make, but expensive to market.
Yeah.
I'm just saying. I don't know, but I don't know anything about that. I don't know if that's true.
It's very likely. So opioid-induced constipation, we're usually giving 25 milligrams in the morning, reduce the dose to once daily if we have intolerance. It's usually abdominal pain. It's cheaper than a lot of the other ones, lots of drug interactions, but like we need to poop. So the next one is naldehyde. This one uniquely in this class is blocking mu, delta, and kappa receptors.
Mu, delta, and kappa receptors. These are all
opioid receptors.
Okay.
Yep.
Huh.
Yes.
I don't know what any of them do.
Oh, well, they're Greek letters
Yep,
for different receptors.
Thank you. Thank you, Dr. Sam. Genius.
I'm here to help out, just call on me. This is slower binding than the other PEMORAs, but it may have a better risk-benefit profile. Highest rate of spontaneous bowel movement in the class, so that's cool. No restriction in patients with renal impairment, unlike the other ones, but tons of drug interactions, and we see a lot of that.
All of them have a lot of drug interactions.
Yes. Yes.
Which, ironically, if they're taking opiates, probably they're also on a lot of drugs.
Mm-hmm.
There's the irony.
Mm-hmm. Yep. So this methyl naltrexone.
Okay.
Is Relistor. And one of the reasons I included this in my presentation is because it gets confused with Resilor.
Yeah.
It's not. They both can act on the gut. They're both like designed to be doing that, but it's not Resilor. That is the non-US brand of
Precalpride.
Nice. This is contraindicated in folks with a history of GI obstruction. I don't know why, but it is. It's the most rapid onset of the class, and that's really this is a methylated form of naltrexone, hence its name.
Does it work?
Naltrexone. Yeah, for pooping, totally. Yeah. It just we're trying to have it not get to the brain is the whole thing. Right?
I can tell you that personally with my use of naltrexone, I know that it has prokinetic activity, but for me it's always been a wah-wah as far as constipation goes.
Yeah, it's sort of debated whether it actually is a true prokinetic. But let's go on to naltrexone.
Okay.
We compound this one. There is a drug for it, but we're not giving it in those doses. So this one, again, it's debated. It antagonizes mu and kappa receptors, but and it upregulates endogenous opioid signaling. It transiently blocks, which is part of the way it works. Pros, it can help with all the other things we use low-dose naltrexone on. Good safety profile. We can use it in lots of people. Tons of side effects. And if it even does have prokinetic effects, which some people swear it does, they're usually transient.
That's kind of how I've seen it.
Yeah.
I think it's still a very, very useful drug.
Yep.
I generally don't see a lot of side effects when I give it in the low dose or ultra low dose formulations.
Yep.
But can I say that it's a strong enough prokinetic in my clinical experience? No.
Right. It might help with other quality of life issues.
Yeah, for sure it does. For sure it does.
And like how many of us have seen when you're titrating people up on it, they get diarrhea.
Yeah.
Like it is totally moving things for whatever reason, but it's not going to be like my choice. It's just like in learning about the physiology of pooping and bowel stuff,
it's there.
It's there.
And I might use it, but most likely I'll probably also use a different prokinetic.
Yep. On that same vein, not one we use, but just for, kind of fun facts, naloxone.
Oh, yeah.
Or Narcan. This blocks opioid binding at the mu receptors peripherally. No one's going to give this for constipation.
I, however, have seen it cause diarrhea.
Yep, that's it.
And my favorite saying, Mark Davis always says, the opposite of constipation is not diarrhea. It's a normal, healthy bowel movement. That's my favorite.
Yep. So anyway, it's this one notably is not a PEMORA. So this and naltrexone are not just peripherally acting, they act everywhere. These are going to, naloxone blocks it peripherally and will counteract the effects as well of the drug. That's like the whole point of it. But it, that affects on the gut. I don't know that I have anything else really to say about that.
That was incredible. I think I am not even sure if I can recap what you just said because so much of it was so new to me.
Yeah.
Can we do a quick recap and maybe piece it together between the three of us?
Sure.
So what we talked about this time is we talked about the acetylcholinesterase inhibitors, the macrolides, and the opiate antagonists.
Yep.
Acetylcholinesterase inhibitors, do you want to do it, Dr. Kapadia?
Pyridostigmine, neostigmine.
Right. So the main one we've seen is pyridostigmine used for other indications. It can be approved for motility if someone has POTS, myasthenia gravis, other concurrent or off-label use for various conditions with motility issues.
Yep.
Macrolides, I can do macrolides. Macrolides are antibiotics, like the ones that we really are going to use are erythromycin and azithromycin. They are used generally in low dose because they work on the motilin, smooth muscle receptor. They are antibiotics, but they're not terrible antibiotics. I have a preconceived judgment on these drugs, but I have still used them in people who are generally cachexic and underweight, but not if you have any weight issues, because that's my favorite fact.
Yeah. And so, a lot of this isn't like necessarily our go-to for treating gut disorders, but it's really helpful to understand the physiology of what's happening with bowel signaling, because we have a lot of drugs that affect it. So whether, we're dipping into them for various reasons like bloating or whatnot, or comorbidities with stuff, also just being informed on how these drugs are affecting the gut and why is super useful.
Yeah. And then the opioid antagonists are specifically for patients that are on opioids but need this kind of drug that's going to only act in the gut, so they still get the effect of their pain medication, but they can have the benefits of the Prokinetic.
Yep, that's it.
That was a great episode.
Awesome.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.